What about vaginal fistulas and Crohn's disease? That's my next topic. And so here's a patient of mine. She's 32. She's had Crohn's ileocolitis for 7 years. She's had a couple of surgeries with distal ileal and proximal colonic resections. She's on dual therapy now with adalimumab and azathioprine. And her bowel symptoms are pretty good. She has 2 to 5 stools a day. She feels generally well. The big problem now is that she passes gas through the vagina, and during her menstrual period, she passes liquid stool. She's a first grade teacher, and she said, you know, passing gas through your vagina in front of a classroom is not real conducive to maintaining order in the classroom. This is a real problem. I need something done. So on exam, no perianal lesions, no palpable fistula in the anal canal. On vaginal exam, couldn't see a fistula. MRI of the pelvis showed a possible small, high rectovaginal fistula. Now, gosh, we would hope an MRI would be able to define the problem, but as you know, rectovaginal or anovaginal fistulas sometimes can be very hard to identify. Sometimes the surgeon will put a tampon in the vagina and put some ethylene blue in the rectum to try to identify it. The patient's right. You know, if they say they're passing gas through the vagina, they got a fistula regardless of what the studies show. So what to do? Well, we could do an exam under anesthesia, try to find the fistula, place a fistula plug. We could ask the surgeon to do advancement flaps, both a flap on the rectal side and a flap on the vaginal side to try to close the defect. We could say, let's just be conservative, try anti-diarrheal medications with the menses. Okay, you pass gas, but you want to go through the surgical procedures, or try broad-spectrum antibiotics. So my numbers are a little funny here, but what about this fistula plug? Anybody in favor? No plug people here? Okay. Advancement flaps. Got a few takers. No surgery. Put up with it. Anti-diarrheal meds. Not too many. Broad-spectrum antibiotics. Let's just talk a bit about these fistula plugs. There are 2 kinds now. There's the pig collagen plug that's been around for 8 or 10 years. I've had 100% failure with those, with patients I've sent for those. I don't know about you, but they haven't worked very well. There's a newer plug that is synthetic, that is a matrix, and it's kind of like just filling the hole with this lattice work, and the idea is that will have cells grow into it so that it just serves as a filler until the cells grow in. That sounds a little more attractive. Surgeons love to put these things in. They have to anchor these. It looks like a golf tee, as you know, and the top part where the ball would sit, they anchor in the submucosal area, and then they push through and then snip off the other end. So it's low morbidity, probably low success rate, but low morbidity. The advancement flaps, at least at our place, our surgeons say, if I'm going to do that, I'm going to do a diverting ostomy, because this is the Hail Mary. If we're going to go in and try to do these flaps, we need every advantage, and not bathing the area with the stool is going to give us a better advantage. So that's a big leap to take a patient to say you're going to have to go to an ostomy for several months in order to do these advancement flaps. That's often a cause for pause there when a patient hears that. Well, there's one study from Madrid from last year looking at fistulas in women, genital fistulas, so retrospective again. And so most patients like mine had a rectovaginal fistula, some anovaginal and some intravaginal. And this doesn't make a whole lot of sense to me that they said 40% just pass gas, 50% pass stool, 55%, I assume that's stool and gas, and then both, they said 5%. I think something got lost in translation there. Nevertheless, our patient would be in that both group. And if you look at the outcomes, you'll notice that the ordinate is not 100, it's 50, so we're already down lower. And the overall response was in the range of about 30%. So that who should you fix these things on? The big thing is to share the data with the patient, that this is a tough thing to fix, and that if the symptoms are tolerable, the patient may elect to say, I'll put up with it, or try antidiarrheals. If they are more troublesome, the rule of thumb is the smaller the fistula, the more likely the success. So you get down to where it's finally so small that it's not worth fixing. If it's a little bit bigger, it may be successful. So range of 30% success depending on what you try. So this patient elected to wait. She doesn't want to get into surgery, and she's not enthusiastic about any further intervention for now. I think if she comes back and says, okay, I need to try something, we'll probably try this newer rectovaginal plug, the Matrix synthetic plug.